All right, well, let's get started. I'd like to welcome everyone to GlomCon today. Today we have our transatlantic collaboration with the YNP in a roundtable discussion format. So we're excited to have everyone join. I'm Dia Wagasback from McGovern Medical School in Houston. Our topic today is focal segmental glomerulosclerosis beyond pathology, should genetics guide our intervention? And leading our talk today will be Dr. Adrian Lungu, a pediatric nephrologist from Romania. Our panelists are Dr. Martin Pollack, a professor of medicine at Harvard and chief of nephrology at Beth Israel Deaconess in Boston. Dr. Olivia Guillon-Boyer, who will hopefully be joining us, is a professor of pediatric nephrology in Paris. Dr. Maria Jose Soler Romeo, a nephrologist and associate editor of CKJ in Barcelona, Spain. Dr. Genson Hall, assistant professor of nephrology and part of Duke's Molecular Physiology Institute at Duke University, and Dr. Albertine van Erd, a YNP board member and clinical geneticist from the Netherlands. So we're happy to have you guys all here, and let's get started with the talk with Dr. Lungu.
Okay, so I should start sharing my slides?
Yes. So if you go down to the bottom green share.
Yes, share PowerPoint, okay, share. Okay, so, perfect. Okay, can you see it?
Yes, excellent.
Perfect. I'm a little nervous, didn't expect it 70 people, but yeah, it's a very interesting topic and maybe a little ambitious, as Kate said. So the topic was based on a paper published in CKG, as a young nephrology platform usually does. This is the paper, Clinical and Pathological Phenotype of Genetic Causes of Focal Segmental Glomerulosclerosis in Adults, by Nicola Lempori et others. A short outline of the presentation. The presentation will follow the paper. It will be a short introduction. We will talk a little more about genetics. After that, we will try to find some kind of algorithm when to do genetic testing and when not. And if you all agree, maybe we can stop at some slides and maybe we can discuss there if we have some kind of questions or something else to discuss. So the introduction, just a short definition of FSGS. It's a histological lesions where we find the sclerosis in part of some glomeruli. What I find it important is that we can classify it as primary, secondary, and genetic. And until now, we have more than 50 genes expressed, usually in podocyte, but also now we get more publications that describe the genes in glomerular basal membrane and other genes like tubular genes or ciliary genes, and they are identified as causing genetic forms of FSGS. Let's start with the gene as the paper. But first, we should discuss a little about the genes involved in the slit diaphragm. We all know about NPHS1, which causes the Finnish type nephrotic syndrome in children. But in adults, as Olivia Boyer suggested, okay. As Olivia Boyer suggested, the NPHS2 mutations are leading cause of autosomal recessive FSGS in adults. Here it is very important to mention that not always the mutations are pathogenic, and some variants, as are described by Kalman Tori at the authors in Nature Genetic in 2014. She described a variant PR229Q, and it is pathogenic only when it associated with specific mutations that alter podocyte dimerization. So these are quite important and also interesting to discuss with the family and to the mode of inheritance. Also, other genes involved are in CRB2, CD2AP, TRP6, and PLCE1. I will not detail all the genes, just some of them. The next genes involved are genes coding proteins from the cytoskeleton structure or regulatory proteins for the cytoskeleton. Here, we should focus on INF2 genes because these are major causes of autosomal dominant focal FSGS in adults, also as suggested by Olivia Boyer. Also, we should mention the genes involved in encoding adhesion proteins like LAMP2 or ITG, B3 or B4. Genes coding nuclear pore complex proteins like NUP93, NUP205, NUP107. We recently have a patient with NUP93 mutations. And this patient is very interesting because even if the gene was described as pathogenic from the team of Professor Hildebrand, the patient doesn't have proteinuria, but has nephrocalcinosis. And this is very important because it's a nuclear gene and it's expressed not only in podocytes, but also in collecting duct cells, just to mention it. Also, it's important to mention the genes involved in nuclear transcription factor like LMX1B or WT1 genes. Here, I would like to stay a little because you also have some patients, and I find it interesting to describe because usually WT1 genes are associated with a wide spectrum of autosomal dominant phenotypes like Dennis-Drash syndrome or Fraser syndrome. And usually you can find Wilms tumor or gonadoblastoma. We recently have had a patient with Fraser syndrome as WT1 mutation, and it was a very interesting discussion what to do because the patient obviously had FSGS, evolved to end-stage kidney disease, and we transplanted her. But we asked ourselves a question because the mutation was in WT1 gene. Would this patient have an increased risk to develop post-transplant lymphoproliferative disorder? So this was kind of important question to us and very important to follow up. I don't know if you have any input or if you have any kind of patient with WT1 mutations and what's your clinical practice here. But it's a very interesting discussion for me, this one. Also, yeah, okay, if you can, if you'd like to add something.
If anyone has anything to add, please either unmute yourself or, post in the chat, we can unmute you. So please feel free to chime in.
Okay, let's detail a little another gene, LMX1B. Here I put some pictures from a patient in our clinic, a classic nail patella syndrome with all like the absence of patella, the onychodysplasia, and also FSGS and kidney involvement, also an autosomal dominant disease. His father had the same features and also end-stage kidney disease. The father and also the patient got transplanted. But what is important here is that Olivia Boyer, in a very nice paper in JSON, she describes LMX1B mutations causing hereditary FSGS, but without extrarenal involvement. So, in my opinion, this is very important to know because sometimes you tend to give immunosuppressive therapy to these patients. And the question is if immunosuppressant therapy has some effect here or not. Also, it is very important because even if you have the genetic mutations, some clinicians tend to give cyclosporine to these patients just to try something because it is known that cyclosporine modifies the cytoskeleton of the podocyte. There are a few papers in the literature, kind of anecdotal, also in my opinion, not only described in the CKG paper. And I feel that these papers just give the clinician, the push to give cyclosporine. And my question is, if you give cyclosporine, isn't it possible that this patient will develop quicker end-stage kidney disease? Maybe also if you have some input here.
Anyone have anything to add in regards to this question?
Okay, maybe we can note them.
Yeah, Adrian, maybe we can go through the presentation and then discuss it when we're done.
So here the important idea is that you can have some mutations that we usually expect to find them in syndromes, but we can get only renal involvement. Also, yeah. Also, it is very. Yes, please.
This is Dr. Glassick. I think it is important to point out that cyclosporin and tacrolimus are very non-specific anti-proteinuric agents. They have no influence on the genetic basis of the disease, and because they're nephrotoxic and would have to be used for a very long period of time, I think their role in the treatment of these genetic forms of FSGS are highly suspect. And I don't think we're going to see many randomized controlled trials of this approach to intervention.
Totally agree with you. Totally agree with you. Yes, but there are a few papers there, and maybe when the clinician has to do something, these papers are enough for him just to give him the push to give cyclosporine. We also sometimes we all feel this pressure just to give some kind of drug to do something. And my question is, if we are not, if maybe we are doing something wrong, maybe we are accelerating the decline of the renal function of these patients. So thank you for the intervention. Also, testing coenzyme Q10 genes, it's also important. They are proven to be part of the FSGS spectrum, and also the addition. It's very important for the treatment because the addition of coenzyme Q10 in the medication can help with the disease. There are cases described with ADCK4 mutations, and the CoQ10 addition improved the clinical spectrum. Also described, there are also other genes, many of them, also from the podocyte. And here I would like to show a family from our clinic where we found DGKE mutation as autosomal recessive disease. 2 children from the 5 children of this family have the DGKE mutation with FSGS and end-stage kidney disease now. But also interesting, this family is consanguineous and has 2 steps of consanguinity in the family. In the last slides of the genes, I let the glomerular basement membrane proteins, the collagen 4 proteins and LAMA5, and these are important because they are usually associated with Alport syndrome, autosomal recessive or dominant. And in January 2019 was published in CJSON a paper from the group of Toronto, where they analyzed 193 individuals, and in 11% of them, they found genetic, with FSGS, of course, they found genetic mutations. What is very interesting that from these patients, 55% have had mutation in collagen type 3, 4, or 5 genes. Why is important? It's important because these patients usually, they didn't have Alport phenotype. So, reading other papers, I found a similar situation. A lot of patients genetically tested with Alport, autosomal recessive or dominant, without other signs of Alport like hearing problems or without specific biopsy for Alport, were confirmed by genetics. So, like a quote from the paper is, despite the fact that these genes are well known to be associated with Alport syndrome, only a few patients were suspected to have this disease, and they receive immunosuppressive therapy. So this, in my opinion, is also a problem. We also have 2 families in our cohort, and one of them, they are autosomal recessive, and one of them, they are autosomal dominant. And we didn't suspect them to be Alport, but only after genetics, we got Alport syndrome. And again, my question is, how should we give the drugs in these families? Because we are pressured to give something, and maybe we are treating with immunosuppressive therapy patients that they don't need immunosuppressive therapy. Also, as Olivia Boyer suggested, I included some genes that are not associated at all with the podocytes. Some genes are tubular genes, some genes are ciliary genes. They are usually associated with tubulopathies, but you can find FSGS pattern. Here is an ultrasound image from a patient from our clinic, and of course he has FSGS and end-stage kidney disease. And to our surprise, we found a mutation in PAX2 gene, which is known as a cause of Kakut and papillorenal syndrome. It appears that 4% of adult onset of familial FSGS and without other kind of extrarenal features can have mutation in this gene. Here the paper in CKG addresses and kind of looks of other papers. I just wanted to highlight that the majority of the studies are quite small studies. There are only 2 studies that have more than 100 patients. There is one huge study from Sadowski with 1,700 patients and one with 900 patients. They usually find the same mutations around 10 to 20%. It depends how they are selecting the patients and how they are making the gene panels. But my idea here is that we need collaboration and we need clinicians to refer more these FSGS patients for genetic testing. Reading and including something from other paper, but kind of over the original paper, is how to differentiate primary genetic and secondary FSGS in adults, how we should apply a clinical pathological approach. And the next slide, we will try to make like a diagram, how to make the steps and how to decide which patients to test for genetics. So now we can differentiate the FSGS in primary genetic or in secondary. And it's important that clinically primary FSGS is a full nephrotic syndrome. In the genetic form, the nephrotic proteinuria is less common in adults. In the secondary form, the proteinuria can be variable, but usually it's subnephrotic. Of course, in light microscopy, in all of these forms, we have FSGS, but there can be some kind of patterns with FSGS, with sclerosis, perihilary, or signs of scarring in the secondary FSGS. In electronic microscopy, there can be some differences where you can have in the primary FSGS diffuse food process effacement. In the genetic, you can have variable it can be segmental, it can be diffuse. And usually in the secondary, you have minimal or segmental foot effacements. So it's not very specific how to differentiate, but it is important just to try to include every patient in these types of FSGS. Okay, when to test? When to genetically test a patient? Should we test all patients? Of course, I would like to test all patients with FSGS genetically. In some countries or in some part of the world, it may be easier. In Romania, it's not so easy. But let's say you have a patient with nephrotic syndrome, and on biopsy you have diffuse foot process effacement. You will try the first-time therapy. If you have response, you will get primary FSGS, okay? If you have resistance, then you go for genetic testing. We have this type of patients. We have like 7 or 8 families, but for our surprise, we didn't get anything, genetic testing. So this is very interesting. If you have diffuse foot effacement, but not nephrotic syndrome, you should go for genetic testing. You should also go for genetic testing if you have nephrotic syndrome, but segmental foot effacement, and non-nephrotic proteinuria, evidence of secondary causes. You should consider it as a secondary FSGS, and usually not genetic. You should not test the patient with genetics. Another slide that I find important is implication in kidney transplantations. In kidney transplantation, a lot of these patients with FSGS will lose the kidney function, and they will need a new kidney. We know that now from papers that the recurrence of disease after transplantation in genetic forms of FSGS is extremely rare. So we can expect a recurrence from 0% to 2%. But if you have primary FSGS, and the patient is progressing to end-stage kidney disease in 3 years of diagnosis, you can expect a recurrence rate of 75%. So it's extremely important. Also, in my opinion, if you go for kidney transplantation, and if you are not sure exactly what kind of FSGS, what's the etiology of the kidney disease, you should go for the genetic testing, and even for the family. There are described cases where the donor developed FSGS on the remaining kidney. So this is my last slide. So we should start the discussions. I don't know exactly how many time we have, but oh, okay. So we have like another 20 or 25 minutes.
Fantastic. So we can kind of start, I guess, go around with our panelists. And if anyone has anything to add, please contribute to the chat as well. So I guess maybe for the first question, if our panelists could discuss basically how important is it to make a clear difference between primary, secondary, and genetic forms? And, how do we think about primary versus genetic forms? It's not necessarily the same thing, or is it? So maybe we could start with discussing that.
And perhaps let me see if Dr. Boyer, can you hear us? Are you able to connect with your phone? I think she may have had trouble. So,
can you hear me, Ali?
Hi, Olivia.
Yes, hi. Yes, I'm so sorry I didn't see any of the slides, I'm afraid.
Okay.
I can discuss with you now. I think the main message here is that it's very difficult to differentiate primary FSGS and secondary FSGS. And some patients may be referred to genetic lab for primary FSGS, but in fact have Alport syndrome or tubulorenal diseases or PAX2 mutations, as Adrienne discussed earlier. So I guess for the clinician, what is important is to look at all extrarenal features to see if the kidneys are small or have a acute or stuff like that on ultrasound, to test the parents if possible with lab sticks, and that can help the geneticist know what to do with the identified variants that they will identify with NGS and see whether it fits with the phenotype or not.
Okay, and perhaps so like very practical. So I'm an adult nephrologist, and so I may be making some wrong assumptions by drawing a scenario for pediatric clinic. But let's say a patient, 10-year-old, comes in with proteinuria and suspected minimal change FSGS. What is the approach? Like at that point, the patient has a new onset disease. Do you even biopsy? Is your approach to do the biopsy like we do in adults? We always biopsy first, but I think, would you give empiric steroids? Or nowadays, would you just say as a first line, let me even not expose the patient to steroid, even the likelihood of genetic disease is low. Yes. It's a non-invasive, non-risky thing. Let me do that. So, and how do you do that?
Yes, that's a very important question with the new developments of genetics. We had a guideline meeting of the IPNA, International Pediatric Nephrology Association, in December to discuss that. So we all agreed that we will continue to first give a course of steroids to the children and test the children who have clear steroid resistance, which is only 10% of the kids, so that we spare 90% of the genetic tests. But then when we have steroid resistance, the availability of genetic results is very, very different in the different countries. For instance, the colleagues who were there from UK and Germany said that they may obtain the genetic results of NGS in 1 or 2 weeks. And if so, they discuss the need for renal biopsy, because if they identify genetic mutations that are true mutations, they won't do the biopsy. In France, we have the results in 1 or 2 months. So for the moment, we still perform the biopsy and then discuss about discontinuing treatment if we have a mutation. And the American colleagues who were here at this guideline conference meeting said that, first they have to ask for a private insurance, whether the genetic test can be performed or not. They may have 2 or 3 months before getting the answer, and then starting the genetic test if the health insurance has agreed to pay for this test. So they don't want to base their immunosuppressive drugs on this genetic test, because it's so difficult for them to obtain the results in a short period of time. And then we had colleagues from all around the world who don't have a genetic test in all patients, and it depends on whether the patient can pay or not, and so on. So so for the moment, I would say we test only the patient after steroid resistance. We perform a biopsy unless we can get the genetic result in 1 or 2 weeks, and hopefully we will have the test for every kid. That's how we do.
Okay. Thank you, Dr. Boyer. And I had a question with Dr. Pollack, but I think his system crashed. So he's just without us.
I just got back.
Hi, Martin. Thank you. So question I had for you is that how is it with regard, and that question also perhaps goes into the effects of calcineurin inhibitors and the whole biology of podocytes and glomerulus. I always, I think that when there is an underlying genetic disorder, why is it that still we have patients who have their first presentation in early adolescence or adulthood? I think a lot what Adrian brought up and discussed, and a lot what is starting to change our mindset is that it's not only the children affected by genetic FSGS, and we should be also thinking on those particularly steroid-resistant FSGS in the adults. So how can a genetic defect not be showing up in childhood, but then presenting itself in the adulthood? What is the physiology and mechanism? And is there any drug, anything we can do for that, or find out about the underlying pathomechanism?
I mean, first I would start by just forget nephrology. I would challenge the assumption you're making that you're sort of saying that genetic diseases should only present in childhood, which we know is not true, right? I think that's point one. Point two is that, FSGS. I mean, I think it has part of our problem in talking about this cleanly is that we keep talking about FSGS as if it were a disease, and it's not. It's a histological finding. It's a response to injury, and so I think it's likely that. So for example, some of these autosomal dominant forms of FSGS that we're interested in, I think that we think basically mess with the ability of a podocyte to repair properly in the face of kind of normal small injuries that occur through life. Obviously that's going to be very different from a genetic defect where you don't form a normal slit diaphragm, where you probably would expect that to see presenting early in childhood, such as people with podocin or nephrin mutations. So I think I think some people have good podocytes and some people don't have such good podocytes because of that they have these mutations in genes that cause abnormal response to injuries, and that so you might present when you're 20 or 30 or 40, depending on all sorts of other insults, and whether probably whether you've had a lot of viral infections and whether your blood pressure is high and who knows what else. That's sort of an answer.
Yes, no, it is. But and you're right. Genetic disorders don't always come in childhood. I think it is more the mindset of it's probably an issue of our sensitivity of detecting them, and then they slowly evolving. Perhaps I thought. I think if the podocytes, for example, have a structural abnormality. How come a patient goes without proteinuria, but suddenly develops that kind of histopathological defect leading into morphological change and proteinuria and disease presentation? Like, is there anything else going on? Is there an underlying susceptibility and a second hit kind of leading to that? How can we understand that? And whether this understanding would help us kind of have targeted therapies in some sort.
Right. No, I mean, I agree. I mean, there must be other factors or second hits, if you want to call them that. Whether it's simply aging or certain infections or hemodynamic stresses or inflammatory stresses. Yes, I agree, and I agree that if one could identify all those things more definitively, then that might help with therapies. I agree with your points.
Can I make a comment?
Yes, please introduce yourself and yes.
It's Fernando Fervenza. I am.
Hi, Dr. Fervenza.
Yeah. So I would just follow on Martin's comment. I think one of the issues that we are forgetting is that take the example of polycystic kidney disease. All right. So we know that polycystic kidney disease, depending on the type of mutation on the same gene, this patient may present with severe disease at age 30 and go on dialysis, and some of them may live until 70 years old and do not go dialysis. So when we talk about genetic mutation, and I'm talking from the adult point of view, my interpretation is that if the genetic mutation in that gene is severe, we won't see it because that is going to present early on, and the pediatricians are going to deal. Is when the genetic mutation is in that gene, but is not so disruptive as it is that it will present early on, is that we are seeing. So I think the variation when we say genetic mutation, that is yes, but because like polycystic kidney, depending on the type of the disruption in the gene is, you're going to see early on, or you're going to see patients that will be age 70 and they still have a creatinine of 2, but they do have a polycystic mutation, but is mild, is not as severe. So this is a degradation why we see in adults and in children difference.
Okay.
I'll just add one comment to that. And I agree with both points. I would just add sort of another layer of complexity when you consider mutations in WT1 and the number of actual isoforms that WT1 has. Disease-causing mutations in any one of those could produce a different phenotypic effect. In the end, we're kind of forced into the position of almost being reconstructionists. So what we see is the end result of this pathologic process on the biopsy, but we don't see what steps kind of brought us to that point. I think with all of the technologies that we have available to us, especially with the boom in discoveries in the realm of genetics with next-gen sequencing and the like, the next big effort should probably be focused on interrogating what these genetic injuries do to the podocyte to alter the physiology, so that if there's any mechanism available for greater understanding of the biochemistry attached to these genetic injuries, we can prop up the podocyte's physiology throughout the course of a given family's or family member's progression to disease. That might be where the therapeutic window is. But ultimately, when you see the lesion on biopsy, you've lost the opportunity to kind of really affect the performance of that glomerulus. And so it kind of leaves you without a whole lot of information to affect any meaningful change therapeutically, unless we start thinking about interrogating specifically the actual mutations in each instance, and maybe coming up with unifying biochemical pathways or aberrant injury responses that can be therapeutically manipulated.
Okay.
So, Ali, can I ask the panel something? So, you know, in terms of a kind of slight change of tact, how do we use this genetic information to inform what we do therapeutically? So, for example, perhaps a transplant candidate, if we offer genetic testing, how are we going to change how we treat a transplant patient to try and either prevent them developing FSGS in their transplant, or to try and reduce the effect if they do develop it in their transplant? So, for example, you know, things like plasma exchange, or, you know, is there something else that we should be doing? What do the panel think?
So in children, you know, when we identify monogenic causes of steroid-resistant nephrotic syndrome, the risk of recurrence on the transplant is minimal. It hasn't only been described in Finland with null mutation in the nephrin gene, and no almost no recurrence with other gene mutations. So in those patients, we will have a protocol of immunosuppression, which is light. On the opposite, in the patients who have been tested with NGS and have no identifying mutation, we may propose a higher level of immunosuppression, maybe discuss rituximab or stuff like that. And in the patient with no mutation and primary steroid sensitivity, whom we are sure that they have a circulating factor related disease and have a 95% risk of recurrence on the transplant, we may discuss plasma exchanges or immunoabsorption in the peri-transplant period. Then, of course, it's important for the familial donor because in recessive disease, we can use familial donors, but in dominant diseases, we have to be sure that the donor is not transmitting the disease.
I think that is a very important point that you just made, because we have seen here at Mayo some patients that they have FSGS and they was resistant to therapy, and well, and they got the kidney from the brother or they got the kidney from the sister, and they didn't bother to check. And then, of course, you do the transplant, and then the donor a few years later start develop proteinuria, and then people say, well, let's go, and then boom, the patient has a mutation, the donor has a mutation. So I think this is crucial that when you come with these patients, that you suspect that you should evaluate to avoid this type of problem.
I'd like to add that I mean, obviously it's important to look for a positive family history, but a negative family history does not rule out a genetic disease. For one, because of penetrance things, but also because the parent might be a mosaic or there might be a de novo. So it's good to ask for family history, but if it's negative, it shouldn't rule out the possibility of a genetic disease.
Absolutely.
Yes, and in some families, we have surprises. For instance, we had an adult patient whose father had been dialyzed, and the patient was mutated for INF2, but the father was not transmitting the disease. So we said, okay. And the mother was not affected at all, but we tested her afterwards, and she was transmitting the INF2 mutation, but she had an incomplete penetrance and no proteinuria. So sometimes, you know, it can be very puzzling, and we have to really check carefully proteinuria and mutation in these pedigrees.
Yeah, like we had the same in INF2 with a mosaic mother who was absolutely healthy, and yeah.
And especially in adulthood, the parents are quite old and may have CKD of other origin. And, you know, sometimes you see a genetic tree and you are sure that one is transmitting the disease, but in fact, he has a diabetic nephropathy or IgA or so on. And it's the other parent who is transmitting the dominant mutation.
So maybe we should not recommend living donors in that cases that we are not sure.
Well, I think in a patient with a dominant genetic FSGS, if you want to consider one of the parent as a donor, you have to test the parent for genetic mutation.
For sure.
And then, can I ask Albertine, what would you put in your panel? How do you decide what genes you're going to test for?
Exactly the question I wanted to ask. So just like to keep it like for the intended purpose of the practical clinical setting, a patient comes. So what panel do you choose, and how do you go about
we have
family?
a luxury position in our expert center that we design our panels ourselves. So in the chat that's connected to the session, I posted a screenshot of our current panel. And, you know, designing panels is basically like a nightmare, because the minute you press save, it's outdated. And there's always the day later you discover there's one other thing you missed. But the panel we have here right now, it's somewhere early 2018. And I think we prepared this session via email, and one of the things that was mentioned is that it's very important to have both syndromal and non-syndromal causes on there, both pediatric and adult causes, because patients may surprise you, and also the podocyte and the not so very podocyte causes on there. And I think if you are able to open to the screenshot, you'll see that we have all those, like the collagen genes, the PAX2 gene, it's all there. And then in pre-test counseling, it takes some time to explain all the vagueness that can be result of the test. But I think it's a good way. I think genetics is really helping us these days, with these panel tests.
So let me ask you something. This is Mario Rubin from Houston. I still want to go back to the basic question, and that is, who do you genetically test? According to the algorithm that we were shown from the paper by Debris, Ferbenza, Glassock, that's a good starting point. But the permutations are incredible. And therefore, should we test everybody? Or I wonder who should we actually test? Because I think it's key, particularly nowadays where the men may not respond to steroid therapy and what have you. So I welcome some comments on that.
Well, I can give you a comment if you want, Mario. And I don't know if Dr. Glassock left the meeting or is still there. But I think, you see, I'm talking, by the way, I'm talking from the adult. I have no idea how children look like, so I'm keep my mouth shut about pediatrics or adolescents. I'm talking about adults. But I think what we do is you have to look at the clinical, because Martin said very well, FSGS is a lesion. So if the biopsy shows FSGS, what does it mean? Well, it's a lesion. So if the patient is fully nephrotic, all right, presents sudden onset of nephrotic syndrome, has proteinuria 14 grams, like I saw yesterday, albumin of 2, the electron microscopy show widespread food process effacement. Well, in principle, you say, in principle, because we don't have a marker. Remember, we don't have PLA2R, we don't have ANCA. So we say, well, in principle, this patient is primary FSGS or is a primary podocytopathy. Let me put it this way. Then you are going to give immunosuppressive therapy, whichever one you want to start. If you want to start with calcineurin inhibitor, prednisone, whatever. The patient goes into complete remission, disappearance of the proteinuria. Then, well, I think this patient, you don't need to do any genetic testing. This patient is in assume, well, is a primary podocytopathy that's responsible immunosuppressive, goodbye. The second, you have the patient that comes and has a proteinuria of 3 grams or 4 grams, albumin is 4.5, you do a biopsy, has a FSGS lesion, but you know that this patient, for example, has a unilateral nephrectomy, or he was born with low birth, or oligonephria, whatever. Well, then you have a explanation. In principle, the patient, like I saw 2 weeks ago, a body mass index of 48, with glomerulomegaly and a scar. Well, in principle, you say this is secondary. This patient, I don't think, in principle, I wouldn't do genetic mutation to begin with, treat them conservative. The issue is the others that come, that you have like 4 or 5 grams of proteinuria or 6 grams of proteinuria, but they don't fulfill. They have 6 grams of proteinuria, and we published this with Dr. Glassock in that review paper. 6 grams proteinuria, but an albumin is 3.5. So it's there, but it's not quite. The patient was treated at another institution with immunosuppressive therapy, didn't respond. Proteinuria went from 6 to 4 grams despite a high dose of calcineurin inhibitor. This is the patient that you should do genetic testing. There is another thing that I like to point out. Dr. Glassock is aware of this. I have been sharing cases with him right and left. You also do genetic testing when it doesn't fit, right? The patient, for example, that is also published in that article in JSON. The patient presented with 5 grams of proteinuria, an albumin of 3.4. It is widespread food process effacement. Well, if you are thinking that this is a podocytopathy, in other words, that a primary podocytopathy is due to a circulating toxic factor that is so devastating that this patient has massive proteinuria. Why is this patient has widespread food process effacement, but proteinuria is mild, is like 4.5 grams, etc. Should raise suspicion that there's something is that, and you should do genetic testing too. And that patient, that is illustrated also in one of the cases that we present in the JSON review. So what I see is need a little bit of like suspicion. You have to look at those patients and say, wait a minute, doesn't fulfill the black and white. And if it doesn't fulfill the black and white, then you should go ahead and test it. Because
and I have a question, Dr. Fervenza. Do you do that?
Dr. Fervenza, because I am younger than you. All right, my name is Fernando.
Fernando. So, do you, in that patient, do you start empiric therapy before the genetic testing, or do you say no? Let me not do anything. Do a gene panel, and when you send it, what do you send it for in that patient?
Yeah, that's an excellent point, because our colleague of Woltresh was talking, and I was going to mention this. And again, and this is the devil is in the detail, all right? Because when we look at Adrian reviewed the literature, the paper, you see, when in the past, a lot of the panels were like 6 genes, all right? Then at Mayo, we start developing one, and 27 genes. Then we went exactly as our colleague Woodtrack says, all right? At the moment you click the send, it's outdated. Then when we published that review in CKJ, we were doing like 48, 50 genes. Like a couple of months ago, we are now doing a panel that includes 350 genes. But the good news is the following. We are paying exactly the same for the 350 genes that we were paying to do the 50 in the past, because the technology has become much cheaper now, all right? So we're doing this. So I would say that if a patient comes, if the patient comes clear cut, sudden onset nephrotic syndrome, 14 grams of proteinuria, just go and treat, all right? And don't need to do genetic panel. The second one, you know that is a genetic, that is a cause that 49 body mass index, glomerulomegaly, low, you don't need it. The other one that I come with low-grade proteinuria with an albumin that is borderline or normal, well, there is no hurry in giving any immunosuppressive therapy to this patient to begin with. Just usually those patients maybe have a little bit of hypertension, just put them on an ACE inhibitor, ARB, all right? And then do the genetic testing and wait. I mean, there is no hurry. We're not talking about rapid progressive glomerulonephritis that we have to start immunosuppression immediately. This is not a disease that goes lose the kidney in a couple of months or 3 months. The other thing, and Dr. Glasshoff knows that also, that is crucial, I think is very important, I think, for us to remember, is be careful about the analysis when you don't look at reports, all right? The other day, we got a patient, Dr. Glasshoff knows that, like the other day, meaning last year. This patient was biopsied twice at a major institution in the West Coast of the United States, and had a FSGS, he had a proteinuria of 10 grams, an albumin of 2, he got 2 biopsies with FSGS. He didn't respond. He was put on high doses steroids, he didn't respond. And then they biopsy again, another FSGS, collapsing, all right? They put on the calcineurin inhibitor, no response, so he came to see me. I already knew the diagnosis before I even saw that patient. Because you see, when you see those patients with nephrotic syndrome, we have advocate, you need to do an extensive panel. You just don't order an albumin and a proteinuria. That paper in CKG shows how difficult around the practice is, because we only have a few patients. Why? Because many patients at the Mayo Clinic have been biopsied without ever checking a serum albumin, all right? So you do a panel. You do the chem panel. We did 3 light chains in monoclonal protein because it was an adult with 55 years old. And bingo, he had a monoclonal peak, all right? So then I look at the electron microscopy and I said, no. let's look at high resolution. Bingo, he had crystals all over in the podocyte. This guy had a crystallopathy, causia podocytopathy, primary podocytopathy. It was nothing to do with primary FSGS. So this is what I'm saying. You have to look, don't just look at the report. Look at that. If it doesn't fit, just start and do a full evaluation. You cannot just look at these patients and 55 years old comes and you don't do a monoclonal protein study. That is not right.
Okay, thank you. I have one question regarding therapy to Dr. Glasak, but before, just as you mentioned, 300 panel, maybe Dr. Van Erde, correct question.
Yeah.
Is it not cheaper just to do whole exome sequencing?
But that's exactly, so one thing I'd like to add to Fernando's comment. I think it's very true that you have to look for where it doesn't fit. But the other way around, it's also very important to look at, well, you know, as doctors do, at what does the patient need. And I think one of the things that was not mentioned yet is also patients in the reproductive age that don't have children yet, that might want to be informed about their chances of passing these diseases on, and maybe having reproductive options depending on the country, obviously. Depending on local availability. I think that's also something very important. If there's a wish to establish a family, then we are more progressive in testing than if the family field is calm. And then, sorry, Fernando, yeah?
I 200% I agree with you. And again, the devil is in detail. When I say that, I fail to inform that we are doing this through a Center of Individualized Medicine project that we have here. So when yesterday I did genetic testing one. So before I do anything like that, I provided the patient with 4 folders, a little for instructing what is the genetic, what are we going to do, what is the implications of doing the genetic testing, what is then the genetic counselor came I left the room, I called, they came, explained to the patient what we're going to do, what was the pros, what was the cons, what was the chances, all this very well in detail. Then the patient signed an informed consent because we are going to do, because the idea is that we do the panel. If the panel is negative, then we go to full genome. Like so. But I think what you said is crucial, because you cannot just go and say, oh, go to do genetic, goodbye. No, the patient needs to be well informed of what was the cost, what was the, first of all, the success rate, what are the costs. You need a full explanation that is crucial. You cannot to these patients.
And Ali, to come back to your question, the way we perform our gene panels now is very flexible because we base them on whole exome data. So the panel that I put on the chat, that's our current panel, but we could update it anytime, and we can also go back in the data if necessary, or when there's new developments. So that's the way we do it.
Okay.
I mean, I also
Martin, yeah.
Yeah. One thing I just want to mention. I mean, I think there's often this impression that genetic testing is somehow clean, much cleaner than other kinds of clinical tests, and it's not. And that's really important for people to realize. I mean, and also prior probabilities of finding a result have a really big impact in what a test might mean. So let me, just to give it a non-genetic example, I'll give a non-genetic example. Let's say someone comes into the hospital with proteinuria, hematuria, you do a kidney biopsy, and they have a rapidly progressive crescentic GN. And you do an ANCA. The ANCA is really high. You know what that ANCA means. You know it's easy to interpret. But if I get a blood sample from Fernando or Ali and check an ANCA, and it's very high, I don't know what that means. It doesn't mean anything. It's the prior probability of a test, of someone having a potosin or nephrin mutant genotype makes a big difference in how you interpret it. Every gene is full of lots of rare variants of unclear significance, and we don't know what all these things mean. It's, there are technical issues in terms of, sensitivity, specificity. so you can't make the assumption that a genetic test is going to answer everything. It's just a wrong assumption that I think people make too commonly.
So maybe can I, for non-geneticists, maybe just briefly for non-geneticists, can I put it, and you correct me if I'm wrong. So you mean that, for example, if we take the podocin gene and there is one mutation in it in one family, that this mutation, like A to G, could be a disease-causing gene, but it could be also just a difference between two individuals, which may mean nothing.
Right. I mean, there's every different mutations. You can make reasonably good predictions about how likely they are to be, pathogenic. I guess my point is that, you will occasionally find something that looks like a pathogenic genotype in someone without any kidney disease, right? So the context matters. I mean, if let's say you have someone who has what looks clinically like autosomal dominant polycystic kidney disease, and instead of sequencing PKD1 or PKD2, you say, I'm just going to sequence their whole exome, and you don't find anything in PKD1 or PKD2, but you see a podocin mutation, and you see a mutation in some, tubular transport protein. What does it mean? I don't know. I mean, it means something different than in the context of someone with, proteinuria or nephrotic syndrome.
Okay, thank you.
That's all I'm saying. The prior probability of it meaning something is important in the way you think about it.
Good. Maybe one going toward the end of the session today, Dr. Glaser. Are you with us?
Yes, I'm here.
So a question. So now we have this kind of an adult patient, has the proteinuria, got the prednisone, didn't respond, got the biopsy. The pathologist said, geez, it doesn't look like 100% foot process effacement, and send it for gene. We send it for a gene panel, and something comes positive out of the 350 or whatever. So what are our options for this patient right now? Like some people think, okay, calcineurin inhibitors on certain mutation, maybe podocyte cytoskeleton stabilizing, but maybe it's just in general antiproteinuric regimen. Is there any option? What do we do?
Well, as I expressed earlier, the use of calcineurin inhibitors in patients who are highly suspected of having a genetic mutation causing FSGS may result in a transient reduction in proteinuria, but this therapy will be lifelong. It's not a temporary treatment. It's not a 3 or 4 month course. It's a lifelong treatment. And the cumulative nephrotoxicity of these drugs, in my opinion, make them very undesirable candidates for therapy in patients with proven or highly suspected genetic mutations as a cause of their FSGS. Angiotensin converting enzyme inhibitors or angiotensin receptor blockers, if they have an antiproteinuric effect, are much more desirable for long-term therapy because they have a low risk of adverse events, and they have other beneficial effects, such as on hypertension and cardiac disease. At the moment, I don't think beyond that we have anything to offer in the way of interventions for patients with proven genetic mutations, except for the rare causes like coenzyme Q mutations where treatment may be beneficial. So the panorama of interventions, specific interventions for genetic diseases, I think is in its infancy. And we need a lot of work to try to define what kind of interventions are best for these patients over the long term. I was going to make a brief comment about some of Fernando's issues, which I agree with completely, and that is I used to think the upper age limit for genetic screening in patients with FSGS who are steroid resistant was age 40. I don't think that's true anymore. I think because of the emergence of the COL3-4 alpha mutations, the COL4 alpha 3-4, means that any age is probably a candidate for genetic screening if they are resistant to steroids and have electron microscopic changes that don't provide a specific diagnosis.
So, Dr. Glassick, you and I think Dr. Fernando or Fernando, Dr. Fervenza. So I think you both are on the KDIGO committee for the guideline development. So will we be seeing no more calcineurin inhibitor in steroid-resistant nephrotic syndrome? Will there be a reference point in sending patient for genetic testing? Will there be a panel for that? Is that?
Well, I don't serve on the FSGS writing panel, so I can't predict what will be proposed. The new guidelines will be out for public comment sometime in the summer of 2019. And I suspect that there will be new recommendations or suggestions compared to the 2012 version. But exactly what the nature of those recommendations or suggestions will be, I can't predict at this moment. I wouldn't want to predict it. It needs a lot of debate.
Thank you.
Are there any other comments or questions as we kind of wrap up here?
For sure, I completely agree with the age. We cannot not limit the age. We have a lot of disease. And of course, we have a problem because we have a lot of genes. So it will be really difficult to have a therapy because we have a lot of genes. Which one will we target? It will be impossible. It will be really difficult. I don't know what you think.
Excellent. I think we all agree. Yes.
I agree with that.
Excuse me?
I said I agree with the statement is that it's going to be a difficult task to find specific therapies for each and every one of the genetic mutations which have been associated with genetic FSGS. That's going to be a formidable undertaking.
Excellent.
Any other comments?
Maybe I will make the last comment. So the answer to the question, should genetics guide our intervention in FSGS? So probably the answer is yes, but we should use our feeling. So thank you. Thank you.
Okay, so thank you so much to our presenter, all of our panelists, everybody, all of our experts. It's been a really great discussion, kind of highlighting what we do know. So much uncertainty remains, but maybe some pearls on how to approach these cases, although it's clearly not straightforward at all. So always an enlightening discussion. Thank you for joining, everyone. Have a great day, and see you next week.
Thank you.
Bye-bye. Thank you.
Thank you.
Thank you. Bye.
Bye-bye. Thank you.